Welcome to the weekly neurology deep dive.
It is excellent to be here.
This deep dive is produced by Amer Gavanini. We are really thrilled to have you joining us today.
We truly are.
Before we examine the data, please note that this deep dive is strictly for educational purposes.
Exactly. It has no commercial goals whatsoever.
And it serves only as a summary of the findings. We highly recommend that you read the full paper to fully appreciate the depth of the research.
Reading the full paper is, it is always the best approach for clinical application.
Today we are focusing on a landmark paper titled Long-Term Tofersen in Superoxide Dismutase 1 Amyotrophic Lateral Sclerosis by Dr. Timothy M. Miller and colleagues.
Published in JAMA Neurology in December 2025.
So, for the neurologists joining us who are pressed for time, here is the rapid, practical summary of this paper.
The key takeaway is that Tofersen, which is an intrathecal antisense oligonucleotide, provides sustained reductions in neurofilament light chain.
And it significantly slows clinical decline in patients with superoxide dismutase 1 amyotrophic lateral sclerosis.
This is over a long-term follow-up of about 5 years.
The clinical bottom line you need for your daily practice is that earlier initiation of the drug leads to better functional outcomes.
And longer event-free survival.
Precisely. Longer event-free survival compared to a delayed start of about 6 months. Safety is manageable, though you must monitor for reversible neurological adverse events.
Based on the findings in this paper, earlier initiation is highly recommended for consideration in your daily clinical practice.
Let us unpack this. We want you to understand the trial design, because our mission for this deep dive is to understand the long-term, real-world implications of this therapy.
The core mission is translating this data for the patients you see in your clinic.
So let us examine the design of the Phase 3 VALOR trial and its open-label extension.
The study enrolled 108 adult participants.
Specifically with the superoxide dismutase 1 variant of amyotrophic lateral sclerosis.
Exactly. And the initial 24-week period randomized participants 2-to-1.
The early start group received 100 milligrams of the active drug,
while the delayed start group received a placebo before crossing over to receive the active drug about 6 months later in the open-label extension.
And the follow-up opportunity was extensive. It was up to about 5 years, with a median follow-up of about 5 years.
That structure provides a very unique window into the mechanics of neurodegeneration.
Because by having an early start group and a delayed start group separated by only about 6 months, the trial perfectly isolates the impact of time.
It does. Amyotrophic lateral sclerosis is a devastating disease, and this specific mutation leads to a toxic, misfolded protein that accumulates inside motor neurons.
And the drug, being an antisense oligonucleotide, reduces the synthesis of that toxic protein
by inducing degradation of its messenger RNA.
We know it targets the protein, but what did the data show us regarding a biomarker efficacy? I found the drops in plasma neurofilament light chain to be absolutely fascinating.
The reductions in plasma neurofilament light chain are a critical piece of this puzzle for you to understand.
Because elevated neurofilament levels indicate neuroaxonal damage.
Precisely. As structural proteins within neurons, they spill into the cerebrospinal fluid and blood when neurons degenerate,
making them a strong prognostic biomarker for disease progression.
And survival. The data shows that maximal reductions were observed approximately 16 weeks after treatment initiation.
And more importantly, these reductions were sustained all the way to 148 weeks.
Without any evidence of the therapeutic effect attenuating.
The numbers at that 148-week mark paint a very clear picture of target engagement. A plasma neurofilament light chain was reduced by about 67% in the early start group.
And about 64% in the delayed start group.
Additionally, the toxic protein in the cerebrospinal fluid dropped by about 21% and about 25% respectively.
Those sustained reductions suggest a fundamental slowing of neurodegeneration. When the toxic protein in the cerebrospinal fluid drops, it confirms target engagement at the source.
The drug is doing exactly what it was designed to do.
Indeed. And when the plasma neurofilament light chain drops by such a massive margin, it confirms that the downstream structural damage to the motor neurons is being halted.
So we have established that the drug hits its molecular target. The critical question for the neurologist listening is whether that molecular change translates to preserving the patient's physical strength at the 148-week mark.
We measure that using the amyotrophic lateral sclerosis functional rating scale revised,
Looking at that specific scale, the early start group declined by 10 points.
while the delayed start group declined by 14 points.
Can you put those numbers in perspective against the natural history of the disease?
Absolutely. On a population basis, untreated patients are estimated to decline by an average of 0.6 to 1.0 points per month on this scale.
So over a 148-week period,
You would expect a natural decline of approximately 22 to 34 points.
seeing decline of only 10 points in the early start group represents a massive deviation from the natural history.
A 4-point difference between the two trial groups might seem abstract, but on this functional scale, 4 points can mean the difference between a patient feeding themselves versus requiring a feeding tube.
Or walking independently versus requiring a wheelchair.
Exactly. And we see a similarly consistent preservation of function across other clinical metrics.
When looking at respiratory strength via slow vital capacity, it declined by about 14% in the early start group.
Versus an about 18% drop in the delayed start group.
The handheld dynamometry data showed a decline of 0.38 points for the early start group.
Versus 0.43 points for the delayed start group.
The delayed start group trailed behind
Across every single metric. The 6-month delay allows irreversible neuronal death to occur.
Which brings us to a finding in the paper that challenges everything we historically expect from this disease.
This is the truly monumental observation for the field.
About 21 to 27% of early start participants actually showed an improvement in strength and function over the 3-year mark.
We are trained to understand this disease as a relentless, unidirectional loss of function. Sustained improvement is incredibly rare.
To understand how rare, the authors utilized a natural history model based on previous large-scale studies.
Because keeping patients on a placebo for 3 years in a fatal disease is entirely unethical.
Based on that model, the probability of untreated individuals experiencing this kind of improvement over time is below 0.01.
And the paper explicitly notes that this finding is statistically significant.
Witnessing actual improvement in over 1/5 of the early start participants completely alters the paradigm.
It absolutely alters the paradigm. We must consider why motor neurons might recover. By lowering the toxic burden, we are likely creating an environment where sick, dysfunctional neurons are given a chance to heal.
If you clear the toxic burden early enough, they can potentially reestablish structural connections.
Exactly. The analogy of a house fire seems very appropriate here for understanding the consequences of the 6-month delayed start.
If you arrive at a house fire after the structural damage is done, the water will still put out the fire.
But you cannot rebuild the burned wood, which represents the dead motor neurons.
You have to put the fire out while the structural integrity remains intact.
That analogy perfectly illustrates why time is motor neurons. The delayed start group benefited from the drug, but they could not regain the functional ground they lost during those initial 6 months.
Their neurons had already crossed the threshold from sick to dead.
Which underscores the necessity of early intervention. You must extinguish the fire immediately upon diagnosis.
Let us move to the ultimate clinical endpoints: survival, quality of life, and the safety profile for daily practice. The survival data clearly illustrates the cost of delaying treatment.
Earlier initiation resulted in about 36% reduction in the risk of death or permanent ventilation.
And an about 48% reduction in the risk of death compared to delayed initiation.
Those risk reductions represent a profound alteration of traditional survival curves. Waiting to see how the disease progresses is no longer an acceptable clinical strategy.
The contrast becomes even more stark when we look at the faster progressing subgroup.
The researchers defined this subgroup based on baseline plasma neurofilament light chain levels being above the median.
In this faster progressing subgroup, median event-free survival was extended by about 3 years for the early start group.
Specifically, it was 254 weeks for the early start group compared to just 76 weeks for the delayed start group.
Extending survival by about 3 years in a fast-progressing neurodegenerative disease is remarkable.
This highlights that we must utilize baseline neurofilament light chain levels as a robust prognostic indicator. You need to identify patients who are at high risk for rapid decline.
Because these are the patients who stand to gain immense long-term benefit from immediate intervention.
Beyond sheer survival, the paper also evaluated quality of life, measured by the Amyotrophic Lateral Sclerosis Assessment Questionnaire 5.
On that assessment, the early start group scored 17 points versus 23 points for the delayed start group.
Because a lower score indicates better outcomes, this points directly to a better preserved quality of life for those who started treatment earlier.
The ability to maintain independence in activities of daily living for a longer period is the ultimate goal.
It is not just about adding days to life, but adding life to those days.
We must also equip the neurologist listener with the safety profile. Most adverse events were related to disease progression or the lumbar puncture procedure.
Presenting commonly as headache, procedural pain, and back pain.
Since the drug is administered intrathecally, procedural adverse events are expected.
And they are generally highly manageable in a routine clinical setting.
However, there is an important clinical warning in the paper. About 9% of participants, which is 9 individuals, experience serious neurological events.
These included conditions like myelitis, radiculitis, and aseptic meningitis.
How should clinicians approach these specific neuroinflammatory risks?
It requires proactive management. While these events are serious, the paper emphasizes they were manageable with standard of care protocols and were completely reversible.
Most participants who experienced these events were actually able to resume their treatment.
For the practicing clinician, you must maintain a high index of suspicion. You have to rigorously monitor cerebrospinal fluid leukocytes and protein levels.
Recognizing these neuroinflammatory adverse events early allows for prompt management, such as pausing the drug or administering corticosteroids.
Precisely. It prevents long-term complications.
As we bring this deep dive to a close, we want to ensure you know exactly how to apply this to your practice tomorrow. Here is the practical summary once again.
Tofersen definitively alters the long-term trajectory of superoxide dismutase 1 amyotrophic lateral sclerosis.
It provides a massive, sustained reduction in neurofilament light chain, slows clinical decline, and extends survival by years in fast progressors.
Early initiation is absolutely critical to maximize these benefits.
And always monitor for reversible neuroinflammatory adverse events.
A delay of even 6 months fundamentally and irreversibly alters the patient's long-term outcome. Identifying these genetic variants early must become the unquestioned standard of care.
We want to leave you with a final provocative thought to ponder. With plasma neurofilament light chain proving to be such a robust, predictive biomarker for treatment response in the superoxide dismutase 1 variant, how soon will we see its widespread adoption as a universal primary endpoint for screening targeted therapies across all genetic and sporadic forms of amyotrophic lateral sclerosis? Thank you for joining us on this weekly Neurology Deep Dive.